Since 2022, we've been working with the Ministry of Health in some of the most remote places on Earth.
Getting there, the last trip we took, it's about 10 drums, so that's 4 to 5 gallon drums of gasoline.
It is the most extensive telemedicine network in the world.
Training community health workers to use advanced digital health technology to drastically increase the quality of healthcare to the indigenous communities.
A patient came in with severe pains to the right abdomen. We have to consult a doctor in order to help diagnose and treat the patient.
We are going to have it in almost 80 communities by the end of the year.
Clinics staffed by community health workers hold a digital stethoscope, an ultrasound, an exam camera, and a doctor in the main city now can examine the person.
The beauty about technology, you no longer have to wait for a consultation on a case. You can do it virtually.
At Health Post, we have a community health worker. The scope of what they can do is quite limited. We decided that we can change that using technology.
Region 9 is privileged to be the area where remote health, as in telemedicine, is piloted. We started initially with 4 sites: Napi, Bukari, Araquarno, and Guns or Massa Canary. These were strategically identified based on the locations in the Deep South and villages in the north.
Guyana has around 800,000 people. Almost 95% of the people live on the coast, so around Georgetown. And the other 5% are all scattered in the hinterlands in Guyana. The furthest away village, Guns Village. To get from Guns to the closest community or regional hospital, it can take almost 5 days by boat. And if the water level is low, there's no way to take the boat, and they rely purely on planes, which can cost almost 10,000 US to charter all the way into the hinterland.
If there is a patient that needs to see a doctor, it will be impossible because we're not able to have a doctor in sites. In 2020, we had just about 56 community healthcare workers. We would have moved from that to now having some 156 community healthcare workers. There are at least 2 of them per center.
We're going to Monkey Mountain today. That's in Region 8. We will do another telemedicine installation. We'll install internet and do the training for telemedicine.
The technology sometimes can be quite challenging. We're training our community health workers to use the technology. So from the tablets that we use, the computers that we use, to the internet-enabled devices, we teach our community health workers how to do this. In addition to that, in most of these villages, they don't have electricity. We connect these computers to a Starlink satellite, and we're using solar to generate the electricity to power the entire system.
You don't have to do anything. It will adjust itself. And then put down the key.
While we're using telemedicine, it's also the technology that is minimizing the use of energy.
Wow, you're Spider-Man. We do a combination between traditional satellite dishes, but also Starlink. So when we go install the internet, we do train the communities in using the telemedicine. At the moment, we're still expanding. We have finished Region 1, 7, and 8. And you can see where we have the gray dots. This is mostly the coastline, where we're still gonna install later this year.
Having somebody in a remote village connected by telemedicine, that person can then help us to improve care because when a patient comes into the facility, they'll talk to the patient. If they realize it's something that they cannot handle, then they go on the computer and they connect with a doctor either at the regional level or at the national level.
Every Wednesday at 2 p.m., every telemedicine site meets.
Hello. Hi, Dr. Mark Allen.
Hey, Mark, are you able to share your screen?
Hi, my name is Indira Anselmo. I am a medics.
Nice to see you, Indira. Good morning.
Hi, I am from Santa Cruz Village.
Hello.
Hi.
A doctor comes on and would guide the interview between the patient and the doctor.
Okay, you ready?
Do I need an assistant?
Let's see. I think you could do it yourself.
Yeah, I do. Oh my goodness.
That's normal. Dr. Allen, can you give us some insight what we're seeing here? Here we can see the eardrum. Okay, looks good, Indira. No beetles.
They had, I think it was a 2 or 3-year-old male patient that had a foreign body lodged in the ear. From camera, we were able to see what this foreign body was and actually remove it using the implements that came within the kit. So that was a very interesting case. And it was a very small beetle
Oh, a small beetle.
that we lodged in the ear, almost to the membrane. So we were able to see it all the way from here and actually remove it using the implements.
If there's a need to do some diagnostic tests, ECG or an ultrasound, or any other test for that matter, then the doctor can guide the community health worker. If you're doing an ECG, for example, you would be able to see that wherever that doctor is located. It can be 400 miles, 500 miles away, but they're seeing what is happening with that patient in real time. And so they would be able to make a diagnosis. And if it's one that warrants emergency evacuation, then we send a plane to pick that patient up and bring them out to Georgetown where they'll have the right level of care.
We're in Monkey Mountain Village. I'm a registered nurse midwife. I'm in charge of the Monkey Mountain Health Center. Telemedicine would be very useful. Most of our mothers here, they don't do ultrasound. We would have direct contact with the doctors to actually see and then tell us what to do. It would save a lot of lives.
It has an amazing impact on prenatal care and morbidity and mortality rates. It has an impact on chronic disease, on pediatrics. Suddenly, when somebody is sick in the communities, are able to go to the community worker, and he or she are now not limited by their own knowledge, but they're able to leverage the knowledge of a doctor in a main city with fact-based information.
If it's something that can be handled locally, then the doctor would advise the community health worker what to do and be monitoring that patient until that patient gets well. It has had a tremendous impact since we've started this program. Apart from us knowing what is going on in these remote communities and types of illnesses that affect people.
Prior, we didn't have a clue in terms of the number of hypertension patients we have, the number of diabetic or the combination. And now these patients have been identified because their baseline illnesses, of course, can lead to kidney damages and would require transplant.
We have had numerous cases of emergencies that we had to send in a medevac to pick up people.
In terms of an emergency occurring in Massa Canary, you are literally going to be there 3 days, and it's just the lost forest and, nature. That's all you'll be exposed.
Without this system, a lot more people probably would have died because we just wouldn't know that they were this critically ill. And so we have really good stories of success where critically ill babies were medevac because of this system. We were able to identify the problems early and bring them out.
Without the intervention of remote health, we could have not achieved that. With remote medicine, we could actually have a doctor at Letton viewing, reviewing a patient, and of course all the records, the vitals can be uploaded. Guns have an advanced kit. We can have an EFAS, an ultrasound done. With a pregnant case, we can have the gestational age identified and we're able to provide the right guidance in these sites. For the first half of the year, some 377 patients were seen, of which 105 additionally was actually emergency cases. There is no established public transport system.
Going to Region 1, it was a combination of cars and hours of boat rides through the mangroves. Region 7 is very foresty and mountainous, so you need to do a combination of boat rides and ATVs. Region 8, you can only access it by plane or ATVs, and the roads partially are very rough or not existing if they're washed away after rainy season. So getting there is a combination of logistical issues, but also communication, because most of the communities do not have internet as yet. So when we go, we also do install the internet.
In the case of having some support from getting there, they might not be even able to get back in the city. There'll be an additional cost for accommodation. There's lots of love when you actually get to associate and provide care for these individuals.
A critical part is leadership. There is always bureaucracy, there are always problems. To make this work in an ongoing manner, and it needs to come from the top. From Minister Frank Anthony and President Irfan.
We are trying to link your health facilities with the main facility in Linden and Georgetown. So that when someone goes to the health center here, if they require a specialist opinion from a doctor, from right here, through telemedicine, we could connect with doctors at Georgetown Hospital.
In Africa in the 90s and 2000s, we have seen how mobile technology completely leapfrogged the need for a landline. And I think we are seeing something to similar magnitude in Guyana. This model of healthcare that you can use the latest technologies and allow a doctor to examine patient remotely is more advanced than many cases what you see in the US or other developed countries. And we're going to have, by the end of this year, 100 communities, even more next year.
The system really had a big impact, and that's why we have taken a decision to continue expanding it. One man said to me, he said, I don't want to go back to Georgetown Hospital. So I said, why? He said, all I do, I walk to the health center here, and I can talk to a specialized doctor at Georgetown.